I am Dr. Stephen Baker. I'm a plastic and reconstructive surgeon, and I serve as the director of the Center for Facial Restoration at MedStar Georgetown University Hospital. We see a multitude of patients in plastic surgery at Georgetown. I see primarily patients that have facial needs, whether it's aesthetic or reconstructive. These can be patients that either have tumors, or patients that have sustained trauma, or patients who have disfigurement from skin cancer, or patients where we work with the dermatologist to both remove the skin cancer as well as restore a patient to their pre-injury form. I became interested in plastic surgery actually by going to dental school with the goal of becoming an oral surgeon. And during my oral surgery residency, I became very interested in surgical procedures of the face, many of which I realized I wouldn't do as an oral surgeon, and I needed additional training in plastic surgery to pursue. When a spot became available in the plastic surgery program at the University of Pennsylvania, I completed that residency and then completed a craniofacial fellowship as well. I love what I do, and this training enables me to take care of all the patients, both children and adults that have various craniofacial and facial needs. Frequently, I'll be in my office or the operating room and have one of my colleagues call me and say, "Hey, can you come up and take a look at this patient?" And we'll develop a team approach. And I think the advantage of coming to our department is you have many people who are world-renowned in their respective subspecialties, and we really work as a team to use all the resources available within our department to get every patient the very best result for their particular condition. You never want to talk anybody into surgery, and you never want to push anybody into surgery. You are a physician. Do no harm is the motto. We do not sell surgery, but we do surgery. And it's really important to me to be a physician first and not be trying to sell anybody anything, because at the end of the day, safety is the most paramount aspect of anything we do as physicians. Most people think of plastic surgery as cosmetic surgery, but really there's a large portion that's reconstructive. It can encompass burn reconstruction, cleft lip and cleft palate repair, breast reconstruction, nerve reconstruction, cosmetic surgery, and there's a multitude of aspects to our specialty. Aesthetic surgery is the aspect of our specialty that relates to not necessarily addressing a problem from disease, but taking somebody who wants to look as good as they feel. In Washington, D.C., it's an extremely active population. People are educated, and many people look in the mirror and they don't see the person in the mirror that they feel. And many times they don't want to look done, they don't want a Hollywood result, but they just want to look naturally more rested. They want to look as good as they feel. As the medical director for the MedStar Georgetown Center for Facial Restoration, I believe my training in dentistry, medicine, maxillofacial surgery, plastic surgery, and craniofacial surgery has really given me the tools to look at a patient's face from the bone outward. Many traditional plastic surgeons think of the face as soft tissue. Sometimes maxillofacial surgeons view it as skeletal tissue. But given the training that I've had, I'm able to look at how the face looks deepest at the bone level and then coming superficially towards the skin. Because optimal results are not just achieved in the bone, and they're not just achieved in the skin. It's really a harmonious balance that's combined to get optimal facial form for each patient. When a patient comes in to see me, they typically report a problem or a condition that they want treated. And my job is to look at them and make sure that their concerns are something that would warrant a procedure. And then almost always there's more than one way in treating a particular condition. I don't view my job as a plastic surgeon to tell a patient what to do. I view my job to explain all the options, the advantages and disadvantages of each option, the recovery associated with each option, and to help that patient make the best decision for them. The reconstructive types of plastic surgery I perform are mainly related to the head and neck. I do skin cancer reconstruction and skin cancer removal. I do cleft lip and palate repair, craniofacial surgery, primary facial trauma, secondary facial trauma, which is devoted to people who may have had an injury treated elsewhere, and they get out of the initial trauma repair and they look in the mirror and they don't think they look quite normal. Almost always, there are things to do that can help optimize and normalize one's appearance. That's a large part of my practice. In addition, I do nasal reconstruction, ear reconstruction. We do jaw surgery to help people with jaw abnormalities. We work with their orthodontist to do that. And mainly any other reconstructive needs on the head and neck, including cranioplasty, where we work with neurosurgeons to heal large wounds on the cranium, either from radiation or trauma or cancer reconstruction. The types of cosmetic surgery I perform are all of those that any plastic surgeon would perform. There's very common operations like liposuction, tummy tuck, breast lift, but where I have a lot of extra experience are cosmetic surgery procedures on the face. That might include facelift, rhinoplasty, chin surgery, neck lift, eyelid surgery. Those are areas where my combined experience of both oral maxillofacial as well as plastics and craniofacial surgery really come into harmony and give me a deep understanding of the anatomy to achieve what I think are very good results. We have two full-time people working in our office that do nothing but work with insurance companies to do pre-certification. Many times they won't give us a pre-certification or they reject it, in which case the physicians in our department will call and do a peer-to-peer phone call with the insurance company, and frequently that's an opportunity to make the best case on the patient's behalf to the insurance company. I think to do cosmetic surgery well, it is very important to have a strong background in reconstructive surgery. I do a lot of rhinoplasties. I feel that I've become a much better rhinoplasty surgeon doing rhinoplasties on cleft lip patients, where I will frequently take rib and use other more advanced techniques to achieve a goal. If you were to do that on a 16-year-old girl and you never had reconstructive experience, it would be really inappropriate. So the reconstructive field gives you the opportunity to really raise your game in a predictable fashion where you can consistently achieve very good results. And when you get comfortable there, you can take those techniques into the cosmetic population. The term facial restoration refers not just to physical restoration of one's face, but the emotional restoration that goes with it. When patients sustain an injury or a condition that results in facial disfigurement, there's not only a physical recovery and restoration, but an emotional one as well. And what we try to do is use our team within the Center for Facial Restoration to come up with an optimal treatment plan to restore the physical form of the patient, which frequently results in an emotional recovery as well. One of the things we do is we have two-dimensional and three-dimensional visual software. And what I try to do is work with the patient to say, what are your goals? Really, the goal of this is to have the patient happy that they did it. And meeting patient expectations is extremely important. And a large degree of meeting their expectations is how well you give an informed consent, educate them about the procedure. Many of my consultations are on PowerPoints, where I not only show them a diagram of how the procedure is performed, I show them multiple before and afters. I show them patients going through the recovery process so that they're very, very well informed going into the procedure. The recovery from plastic surgery varies from procedure to procedure. Let's take facelift, for instance. We try to use a technique here that really minimizes bruising and swelling. So I've had patients go out to dinner with their friends as soon as 5 days after the procedure, But realistically, most patients, I say, would be about 3 weeks before they'd want to go out in public. The postoperative pain, many patients describe it as a sunburn. Many patients don't require that much pain medicine, but some do. And that's the important thing, is not every patient behaves the exact same way. Procedures like abdominoplasty traditionally were very uncomfortable, but advances in postoperative pain management with injectable slow-release pain medicines have made it a procedure that's gone from 3 weeks of a very slow recovery to you trying to tell the patient not to do as much because they shouldn't be doing as much as they want to do. So now I have patients that want to go to the gym a week after, and I have to convince them to stay home. So sometimes patients will come into the office with some anxiety or a little bit of alleviations regarding cosmetic surgery. And generally for those patients, I do need to tell them it is a surgical procedure. Just because it's cosmetic doesn't mean that there's not a recovery. And generally you get a sense of when somebody wants to do it. If they have anxiety, I'm like, you know what, this probably isn't the time for you. You explain the consultation, you give them a good education of it. And if there's still a little bit of ambivalence, probably not ready for it. The patients that are ready, that come in, are like, do you see this? Every morning I look in the mirror. I can't stand it. I hate it. I want it gone, whatever it takes, okay? That's a motivated patient. One of the tools that we've been using for over 5 years now is something called the FaceQ, which is a patient-reported outcomes measure. So when we have facial cosmetic patients, they fill out a questionnaire before surgery, and then they fill it out a month after, 3 months after, 6 months after, and a year after. And what we can do is we can actually quantify and apply data to how happy the patients are after a given cosmetic procedure. We've been part of a study group that's done this for facelift, eye lift, fillers, rhinoplasty, chin surgery, and jaw surgery. And we've published numerous papers on this. And one of the things we found is that every patient has statistically significant improvement of patient satisfaction. How is this measured? The questionnaires would have questions such as, how do I feel when I look in the mirror? How confident am I going into a party where I don't know people? Do my peers think I look rested? So these have been validated questions that help us figure and determine who are the best candidates for a procedure. The ways we work with the dermatology colleagues to treat skin cancer is in a team-centered approach. With patients who have basal cell or squamous cell carcinomas, if they can't be resected in 1 or 2 small operations in the office, we'll work with a Mohs surgeon who will remove the lesion with the minimal amount of normal tissue being removed, and then the plastic surgeon will repair the wound associated with the removal. These types of skin cancers aren't usually removed in 1 day and repaired in 1 day when a Mohs surgeon is working with a plastic surgeon. Typically, the Mohs surgeon will remove the lesion the day before the plastic surgeon reconstructs the wound that occurs as a result of the skin cancer removal. And by using a team approach, you have the expertise of the Mohs surgeon who removes the skin cancer with the removal of the minimal amount of normal tissue, combined with the expertise of the plastic surgeon, who is the surgical specialist that is trained to reconstruct that area with the least amount of telltale signs that a lesion was ever there. Rhinoplasty is a particular operation of working on the nose, either functionally or aesthetically. And as a craniofacial surgeon, that is a common procedure I do in my practice. It's a procedure that I've lectured on as a visiting professor for the American Society of Maxillofacial Surgeons, and a topic I've actually written a textbook about. Frequently, patients will come in with a combined problem of both breathing difficulty as well as a cosmetic concern that they'd like addressed at the same time. So in rhinoplasty, what we do is we can alter the underlying cartilage and bone of the nose and redrape the soft tissue to achieve a patient's goals and desires, while at the same time improving their breathing. We want to make sure that we are on target with our aesthetic goals as well as the functional goals. So typically I'll sit down with them with my textbook on rhinoplasty and show them diagrammatically what we're going to do and how that procedure will work and affect the change that they desire. And then we get three-dimensional photos and we can do a prediction image of their nose. And we also can use patient-reported outcome measures to kind of test the satisfaction of our patients that we've done. And I'm very proud to say that in 5 years of patients using these tools, that we have a very high patient satisfaction rate documented with objective data, which actually resulted in the best presentation of the year at the annual rhinoplasty meeting, which is sponsored at the American Society of Aesthetic Plastic Surgery. Many patients will come into my practice complaining of a small chin or a long chin or a wide chin or a narrow chin. The term for chin surgery is genioplasty, which can be done one of two ways, one being an implant, or two, actually moving the little bone called the chin in a new position. What patients don't know is that really a chin implant, the only thing it can do is move a chin forward, but it can't lengthen the chin, widen the chin, correct asymmetry, or do any other movement. Both are equally easy to perform if you're trained well, but most people get a chin implant because that's all the surgeon knows how to do. However, by moving the bone forward, there are certain muscles under the neck that attach to the back of the chin. And when you pull the chin forward, you tighten that, giving a much more powerful rejuvenative effect to the patient's lower facial form. And I have many middle-aged women or women in their 40s or 50s who come in for chin augmentation, and all their friends think they've had a neck lift because it's such a powerful procedure for taking up the slack and the excess skin. And this is one of the advantages of actually moving the bone versus just putting a piece of plastic in as an implant. As a craniofacial surgeon, both procedures are equally easy for me to do, and ultimately it's the patient's choice. But I think most patients see my results of both implants versus osteotomy. Probably 90% go with moving the chin because they see the power of that operation compared to just putting an implant in.